Many times you have patients who are severely low in vitamin D. They'll be getting prescribed 50,000 units once a week by a doctor. I sort of come back and I say, it's a sunshine, it's a hormone actually, not a vitamin, it's a hormone, but also did God mean for us to be outside one day a week, getting our sun? Mm-hmm. So I sort of go back to that aspect. So what we were looking at doing when we came to a study and found out 84% of our patients were deficient, we wanted to look at a different delivery system, to see if we could find an efficacious delivery system. And in this case, what we did was we found this spray vitamin, from Dr. Spray from Spray Lab, Dr. Clyde Spray. So what we did, we tested it and did a study in the clinic using between 5,000 and 10,000 units, daily, depending upon where the patient's baseline vitamin D levels. We had one patient who had actually no vitamin D level. That was less than 5 nanograms, when she measured. She had congestive heart failure. She could not lose any weight. She was about as wide as she was tall. Italian lady, one of my CHF patients for a while. And so, but we had 38 patients that we put on the vitamin D spray, and the greatest majority of them on 5,000 units every night. Mm-hmm. Came back later, 90 days later, and then followed up. 90 days, and then another 90 days, 6 months later. And we brought vitamin D levels up tremendously. So it's a buccal delivery spray in the cheek, or you can use sublingual, like nitroglycerin is being given in EMS. The delivery system is the same. And after we came away with our studies for initial L-arginine study, we found that basically our patients really needed to be, most often, our patients needed to be on at least about 5,000 units a day. I and myself did a concurrent study with the first L-arginine study, and so what had happened was I had not ever been tested for vitamin D, and so I found my vitamin D. I got my vitamin D level done, and my vitamin D level was quite low at 26, and at that time I was running 5 to 6 days a week. Here I was thinking I was getting enough sun, vitamin D from the sun, everything. From up here and everything. I was doing triathlons and marathons at that time. And I had a vitamin D level of 26. And it blew me away, Bill. I was going, why was I not getting enough vitamin D? Well, it turns out that my medical history, I've had epilepsy for a little over 50 years now. And my neurologist told me that we now know that many anti-seizure medications pull vitamin D out of the bones. So I really didn't know that in this time period. I would have checked my vitamin D levels earlier on. So here I was, when he told me that about 12 years ago, I started doing my bone mineral densities and found myself to be osteopenic, which was pre-osteoporosis. So here I wasn't too happy about that, being a runner, being osteopenic at the time. And so what I did was I went on the study at the time. We were putting our patients in that first study, we put our patients on 10,000 units a day for 90 days, and then we repeated the labs. And so I did that concurrent study. I brought my level from 26 up to 79 nanograms per milliliter, and I kept my vitamin D levels above 70 nanograms. Since that time period. Now, what that requires from me is it requires for me to take anywhere between 10 and 12, 13,000 units a day. To achieve those levels. But what I've also done is I've done my bone mineral densities every 2 years. And after the first 6 years, my first 2 years, my bone mineral density went up 6%. Next 2 years, it went up 5%. And the next 2 years, it went up 3%. But after the first bone mineral density, I'd gone from an osteopenic state back into a normal bone mineral density. I didn't take any calcium supplements, just using the vitamin D deficiency, where you have a calcium absorption, strong correlation between D deficiency and calcium absorption, henceforth osteoporosis. So this is one of the things that we took some patients who had osteoporosis in their late 70s, early 80s, put them on high doses of vitamin D, brought them down to an osteopenic state, later on, and following them. So that's just one aspect. Now you look at about 115 different autoimmune disorders, which Dr. C was talking about, remember autoimmune, type 1 diabetes, type 2 diabetes, or autoimmune disorders. So you looked at that. That is how we could go ahead and, by raising our patients' vitamin D levels to between 60 and 80 nanograms. It's a good study out of the University of Kansas showed that when patients achieved those levels of 60 to 80 nanograms, all-cause mortality was reduced by up to 60%. That was a pretty big number. So we're looking at from that talk, we're talking about from cancer, we're talking about cardiovascular disease. Those are big numbers in that aspect right there. So we've been really utilizing pretty much 5,000 units a day for the majority of our patients. We know that as you get older, you don't absorb as much sun, to your skin. The heavier we are as a society, the less vitamin D gets absorbed through the adipose tissue. And then also, the darker colored skin you have, the less vitamin D gets absorbed through the melanin. So Dr. Siva then went ahead and got his vitamin D level checked because he's in the cath lab, or he's in the gym 6 days a week, or he's here. And his vitamin D level was low. So that's why when he was telling you, that's why he does his vitamin D, is one of his staples. An interesting point. We have a fairly large Indian physician population here. And they come over here to the Heart Institute and everything for testing. And 100% of the Indian physicians, that got tested for vitamin D were deficient in vitamin D, Bill. 100%. It was one of those things where they go, they're totally blown away. So it's going to be interesting to see. If this pandemic rolls out through India, how that country is going to be dealing with, because if they're starting to use higher doses of vitamin D, with this pandemic, how this is what I think important, why we have a patient population of pulmonary arterial hypertension. We have a large population that we treat here, and since we've had these patients sheltered for a long time, we are delivering vitamin D spray to them and keeping their vitamin D levels high during this time period right here.
And I would imagine that there isn't one patient that would know they were low in vitamin D.
No, I ask whenever I speak, when I speak around the country and overseas, I start out by saying, well, the raise of hand, who knows their vitamin D level?
Right.
And it's amazing people don't know their vitamin D level. So as part of the educational processes in my clinic, and if you go to my clinic and ask my patients, they know their vitamin D levels,
right?
Because they've been counseled when they first take it, and they got a vitamin D level of 15, and so we put them on 10,000 units a day to go ahead. We want to quadruple that level to try to get the levels above 60 nanograms. And it's amazing because that one woman I told you about, when she had less than 5 nanograms, she got her level up to 81 with 10,000 units. Mm-hmm. Guess what? In the 2-month time period we did that study, she lost 17 pounds. Interesting. Strong correlation between vitamin D deficiency and insulin sensitivity. Yep. So if you're taking those foods in and there's no circulating vitamin D, pancreas wants to sort of take a vacation. So it won't sit there and produce the insulin and everything to go ahead, and break down. So it's saying, hey, I don't have to work. But you need that vitamin D to go ahead and stimulate the pancreas to produce insulin. So she actually thought she had cancer. Because she had never lost 9 pounds in the first month, 8 pounds in the second month. She came to me, she actually thought she had cancer. She was losing weight without. That's right.
Wow.
Yeah. So think about what that's going to do for, we've got a whole generation of people with.
Right. Who don't exercise and don't know what they can do to.
Exactly. That part of it.
Yeah.
It's amazing. It's one of the things. As Dr. Siegel was saying, now the ACC is the only vitamin D is the only vitamin that is endorsed by American College of Cardiology. It is really it's a staple for our patients in that aspect that they're going through, and it's proved so worthwhile. I can go off and talk about all kinds of benefits for different patients that have used it and that part of it there, but it's been a staple for us. We have a good amount of it in the Arginetix, and so again, if you look at one part that has a really good amount of vitamin C, as Dr. Sieber talked about, the different antioxidants that we want to utilize for, and then the maximum absorption with our estrogen in the gut.
That's remarkable, and it's interesting. It's not lost on me that this is maybe it's correlation with everything that's happening with the COVID virus situation internationally is that there's now just percolating this conversation about vitamin D, and in a way that from the layman you'd never have heard about it before. And maybe that's one of the fortuitous things that's happened now, is that patients are becoming educated and then understanding that their immune therapy is something that they've got to take responsibility for.
Yeah.
And it can be done as efficiently as what they consume from a supplement level or from what they eat, and not just as exotic as how much exercise they need to get or being outside. Yes. There's some very simple things that a patient can do on their own.
Every patient, again, as Dr. Steele pointed out, every patient is sort of tailor-made, okay, at the Heart Institute, and through his years of experience of treating our patients, it's truly, we've been blessed to be able to have an environment where we can do everything under one roof. Mm-hmm. Okay, so we don't have to ship that patient out and sort of lose contact with how that patient's doing. But we are able to go ahead and be able to monitor, okay, through our labs, monitor different levels of how they're doing, so like the vitamin D level, to see if they're making sure those are safe in that aspect, making sure how they're doing with their dietary regimen, making sure how they're doing with the medication regimen going through. This is an exciting time. I just brought on a new RN. I have several nurses in my clinic that work on me, but I've just brought on a new grad, and her appetite is voracious with regards to what she wants to learn about cardiology and learn about pulmonary hypertension. And it's interesting because of this. One of the reasons we developed Arginetix was for our PH patients population. It's one of the pathways for the treatment modalities of medications. Follows the nitric oxide synthase pathway. So she's just absorbing all of this information. That's the generation, okay, that is going to be out there. They're going to be having to really deal with the next coronavirus. Yep. Because they're going to be, as Dr. Stephen points out, it's just a novel virus. We're going to have another one, but there's sort of a little bit of a mutation going on process because they're getting a little more resistant. And are we going to be prepared, okay, a little better the next time down the road? And part of that process is, for me as a nurse, I just have to add this one other caveat: are we going to be protecting our healthcare workers better, okay, to take care of the patients, because we know the job that we are to do. And I've been doing critical care nursing for over 3 decades. Emergency, critical care, open heart. Been blessed to be able to be with Dr. Sifa for 18 years. He's in the pits, I'm in the front line. But it's unfortunate we've lost healthcare practitioners, nurses, doctors, respiratory therapists that we've lost to this virus. Due to the treatment modality in the course of their duty, the course of their passion, the course of their role in this process right here. So I think about them on a daily basis because of my time in this profession. And my heart goes out to the families that have lost them.